Ultimate Guide Module 1 Patient Access Services. Learning Objectives. To demonstrate an understanding of the scope of services performed in a typical patient access services organization, including pre-encounter services, encounter services, post-encounter services, and general responsibilities. Module 1 Self-Assessment. Question number 1. Patient access services is an integration of services that include all of the following except A. Integrates data collection necessary for financial integrity, clinical care, and discharge processes. B. Serves as the official identifying entity for the hospital when declaring the authenticity of a patient medical record information. C. Provide accurate statistical reporting. D. Allows for the management of confidential communication of pertinent data throughout the continuum of care to eliminate repetitive questioning. Question number 2. As part of the pre-encounter process, the term used for validating with third-party payers that a given plan is active and ascertaining the patient's deductible, copay, and limitations is A. Payer authorization, B. Financial prerequisition, C. Verification of benefits, D. Explanation of benefits. Question number 3. The formal process of comparison of productivity, customer satisfaction, quality of service, cost, and other indications with similar work groups is termed A. Statistical reporting, B. Benchmarking, C. Consumer assessment, D. Marketing. Question number 4. All of the following are types of benchmarking except A. External, B. Competitive, C. Functional, D. Community. Question number 5. The collection, dissemination, and storage of registration information, including demographic, financial, and clinical data before the patient's arrival is A. Financial screening, B. Patient admission, C. Pre-registration, D. Patient check-in. Question number 6. Activities that include but are not limited to preps and testing are called A. Clinical prerequisites, B. Lab work, C. Pre-registration, D. Pre-encounter tasks. Question number 7. Obtaining permission from a third-party payers before services are rendered to the patient is called A. Financial counseling, B. Financial assistance, C. Pre-authorization, D. Pre-registration. Question number 8. The process, procedure of providing the most appropriate location and level of service necessary for optimum clinical care delivery to the patient is called A. Patient placement, B. Bed control, C. Bed management, D. All of the above. Question number 9. The documentation of arrival and departure to allow caregivers to know where a patient is at any point of service during an encounter is called A. Patient transport, B. Concierge services, C. Patient tracking, D. Patient check-in. Question number 10. Services provided to respect patient rights, facilitate patient or family responsibilities, and provide confidentiality for the patient while meeting the needs of the family and visitors. A. Family liaison services, B. Social work, C. Patient relations, D. All of the above. Question number 11. The process of electronically or manually applying appropriate predetermined fees associated with service delivery is called A. Upfront collections, B. Charge capture, C. Estimate calculation, D. Pre-registration. Question number 12. This process provides timely, summarized information for process improvement, administration and management surveys and audits, as well as on trends and patterns. A. Data gathering, B. Statistical reporting, C. Departmental audits, D. Quality assurance. Question number 13. Blank is the objective measurement of the level of satisfaction as expressed by customers in relation to global processes or very specific issues. A. Customer satisfaction measurement, B. Patient relation surveys, C. Suggestion boxes, D. Thank you notes. Question number 14. The ability to professionally manage the volume of patient registrations while maintaining the desired level of data collection quality is called A. Competent work, B. Productivity and accuracy, C. Working under pressure, D. Meeting patient expectations. Question number 15. Patient access staff competencies are enhanced and improved by providing patient access personnel with specific goals and are measured by comparison to established performance standards on an annual evaluation. A. True, B. False. Question number 16. Admission, discharge, transfer transactions reflect the heart of traditional admission and bed control functions. These functions are sometimes called A. Pre-encounter functions, B. Encounter functions, C. ADT, D. Patient throughput. Patient access services. What is access management? Access management is the management of patient access services in healthcare delivery. As we will learn in this module, access management may not be limited to traditional admitting or registration departments. What are patient access services? Patient access services provides quality services in registration and all of its supporting processes to patients, providers, and to payers into, through, and out of their healthcare experience. The primary challenge of patient access management is to find a way to say yes to the patients in need of healthcare services while ensuring that the providers of those services are sufficiently reimbursed to continue in their delivery. The patient's first contact is usually with an appointment or registration function and not necessarily with a clinician. These employees, along with other front-end employees such as receptionists, must receive extensive training in service excellence behaviors needed to fulfill the mission of patient care and revenue cycle excellence. Such front-end staff comprise the patient access services function at most facilities. To provide best service, they should be responsible for orienting our patients to financial and clinical procedures within their areas of enterprise. General responsibilities. Broadly speaking, patient access services may include admissions, registration, patient finance, financial counselors. It may even include guest relations and transport. Additionally, in a hospital setting, patient access services may be provided by both central and decentralized departments. The level of centralization is the extent to which the department processes are controlled by a single management team within the hospital organization. In such departments, access management processes are managed by the Patient Access Services Department, PAS. The PAS department will generally control the following types of functions: inpatient and direct admissions, same-day surgery and special procedure registration, emergency department registration, centralized scheduling and pre-registration, centralized insurance verification and financial counseling, general and point-of-service cashiering, patient placement and census management. Versus decentralized models. Organizations may have a centralized or decentralized focus or a combination of both approaches. No matter which approach is selected, the same general access management responsibilities apply. Sound access management practices must be employed in order to achieve success in either model. Patient access services generally responsibilities consist of permanent identification of the patient, providing information to the patient and/or family, determining patient's special needs. Permanent identification of the patient includes proper hospital identification numbers, Master Patient Index, MPI, updated demographic information, copies of insurance information, and photo ID if appropriate. Determines primary insurance payer through completion of the MSP, Medicare Secondary Payer Form, and through coordination of benefits rules. Usually for the Master Patient Index, a minimum of 2 identifiers is required. Provides information to the patient and/or family includes advanced directives. In some facilities, this information may be provided by the nursing units as well as the Patient Access Services Department, and the information requires under the Patient Self-Determination Act. Patient Right to Privacy of Protected Health Information, PHI, under the Healthcare Information Portability and Accountability Act, HIPAA. Initiation of the processes for applying to financial assistance programs or government-funded programs. Admitting diagnosis and the reason for the visit may indicate the need for reverse airflow or positive airflow rooms, continuous monitoring, specialty bed or equipment, or even the need for a foreign language interpreter. Determining special needs of a patient also includes desired contact from spiritual care advisors, the use of telecommunication devices for the deaf, TDD, phone at home or the patient support person must use a TDD phone, requests to be listed as confidential or private, pre-encounter services. A well-developed pre-encounter program is the key to access management success. Pre-encounter activities include pre-admitting and gatekeeping, resource scheduling, payer authorization, benefit verification, and pre-encounter communication. Customer service and referral services. Referral services are the part of the access management process through which patients are referred to the healthcare provider. The primary customers of the Patient Access Services Department are patients and their families, physicians, and the payers, but there are many subsets such as nursing and physician staff. Patient Access Services customers are both internal and external. Gatekeeping and referral services. Patients may be referred for services through many different channels, such as physician to referral center to physician, patient to referral center to a physician, managed care to a specialist. Regardless of the channel, the goal should be to obtain and maintain quality service and high levels of customer satisfaction, as well as to sustain the referral flow. Patient assessment. Patient assessment involves the review of the patient's needs and expectations for the services to be provided. The review will have to be both a clinical and a financial focus, should be included in the discussion about the possible alternative options for care and aftercare planning. The review will result in a development and documentation plan of care, written and or oral, for the patient and the family. Resource scheduling. Resource scheduling involves receipt of a request to arrange a place, equipment, and or persons for a defined date and time, including but not limited to physician appointments, ancillary services, operating room, and inpatient beds. It also involves confirmation of availability of service, and actual scheduling of service will follow the request. Finally, documentation of the scheduled services will be provided, communication to all involved parties. Who, what, where, when, and how. The who could involve you, the physicians, the schedulers, medical directors, and IT. The what, the rooms, the equipment, the staff. The where, the hospital-wide physicians within the department among the specialty groups. The when, access whenever, anytime, availability updates in real time. And how, local control of master schedules, role-based access to control who has access and when. Pre-registration. Pre-registration involves the collection, dissemination, and storage of registration information, including demographic, financial, and clinical data before the patient's arrival. Pre-registration is no longer just a value-added service purported to improve patient flow. Today, it is critical activity that enables the efficient operations of all effective patient access services departments. Patient and family education. A patient education program is planned by utilizing the results of the patient assessment. The plan includes a determination of available materials and appropriate teaching tools and methods, the timing of the teaching, and the audience, for example, the family as well as the patient, and any age-specific criteria, as well as the content and information to the patient's needs. Feedback is sought from the patient and the family to ensure comprehension and understanding. Clinical prerequisites. This process involves the determination of required clinical prerequisites for planned healthcare services and is obtained from the physician orders and other established protocols. Clinical prerequisites are not limited to preps and testing. The procedures must be communicated to the patient and the family to ensure timely completion and compliance with the requirements. Collection and review of previous testing results may be required before services are rendered. Financial prerequisites. Financial prerequisites involve assuring that all the appropriate payers have been identified and the requirements have been met, and that there has been communication with the patient about their financial obligations before services are rendered. Payer authorization. Payer authorization involves approval from third-party payers to provide specific care in a particular setting. Also involves written or electronic assurance that the services provided will be covered under the terms of the patient's healthcare plan. Verification of benefits. Verification of benefits involves validating with third-party payers that a given plan is active and ascertaining the patient's deductible, copay, and any other covered services or service limitations. Pre-encounter communications. Pre-encounter communications involves oral or written information shared with patients, their families, care providers before arrival of the service, including but not limited to answering questions, providing information on preparations for tests and treatments, directions, scheduling, and appointment information, financial arrangements, and phone numbers to call with questions or concerns. Encounter services involve activities performed on the date of service. Encounter services include ADT transactions, patient check-in, inpatient admission and outpatient registration, payment and cashiering, patient placement, census management, patient tracking. Encounter services also include benefit verification, financial counseling, payment authorization, concierge services, order entry, charge capture, and departure and discharge. Encounter services. Patient Management System Transactions, ADT. Patient management systems are used to record and manage admission, discharge, transfer transactions, ADT, in healthcare settings. These systems reflect the heart of the traditional admission process. ADT systems record patient demographic and financial information that will be used later in clinical and billing processes. There are many patient management transactional systems or ADT systems, such as Epic, Cerner, eClinicalWorks, Allscripts, Meditech, etc. Patient management system transactions also affect statistical data for census management, bed utilization, and length of stay control functions. Nearly all of today's facilities are computerized. ADT transactions record these routine patient activities online. Access management departments assume the responsibility for ensuring timely and accurate input of data to ensure synchronization with other nursing and ancillary service systems that rely on accurate information regarding patient demographic and billing information, as well as the patient's status and the patient location information to deliver the services they provide. Patient care, billing, and customer service may be adversely affected when correct patient and ADT information is not reflected on interfaced clinical and financial systems. Patient tracking information, concierge services, and resource scheduling systems all depend on complete and accurate ADT information for a sound fiscal management. This can occur at any point of access in centralized and decentralized model. All processes related to activation of an account, including a review of demographic, guarantor, insurance information, copying cards, obtaining consents and signatures, requesting and reviewing previous medical records, encounter summary, or anything to do with an actual initiation of an encounter. Encounter payer authorization. Encounter payer authorization involves the approval of a third-party payer to provide specific care in a particular setting, includes written or electronic assurance that the services provided will be covered underneath the terms of the patient's healthcare plan. Encounter verification of benefits. Involves validation of the third party that is given an active in ascertaining the patient's deductible, copay, and limitations. This information cannot be stressed enough. Looking at the information below, the patient can receive a schedule from the provider's office. The next should be the entry of the patient's demographic information. The next following step should be to verify the coverage of the benefits with the patient's primary and secondary payers. The fourth step should be, where required, initiate a prior authorization request and obtain approval for the treatment. The fifth step should be to update the hospital's revenue cycle system or the patient's practice management system. And last but not least, in my opinion, you should also have a conversation with the patient and or the provider's office to let them know exactly what the benefit verification is and whether their authorization has been approved or not, so they can act accordingly. The process of providing the most appropriate location and service necessity of optimum clinical delivery to the patient placement. In many hospitals, this process is referred to bed control or bed management. Patient placement includes the requesting of a bed for inpatient, outpatient observation, etc. It involves the collection and documentation of the information necessary to determine that the requirements for the requested level of service or care are met. Patient placement. When a request has been determined to the appropriate level and service is available, arrangements are made to ensure the patient's timely arrival. This may include transportation arrangements. The patient placement involves a close working relationship with the nursing unit, but requires a central philosophy to maximize the utilization of all resources. Census management. Census management involves the accurate accounting of the patient activity within or across entities and accurate use of the data interfaced to fiscal and other statistical systems. Patient tracking. Patient tracking involves the documentation of the patient's arrival and departure to allow caregivers to know where a patient is at any point of service during the encounter. What began in a traditional hospital environment as a patient tracking and bed cleaning has expanded greatly in the current healthcare environment. Extended services, often involving many physical locations within the healthcare organization, make it more challenging and yet more important to be aware of a patient's current location. Computer systems linked to scheduling are one approach to patient tracking. Sophisticated computerized systems that would require no additional recording of a patient's comings and goings on paper or online may be the wave of the future. And pretty much I'm going to say the future is already here. We practically do everything with a computer system to really know where a patient is at any given time. The only time most organizations default to paper is when we're in a downtime. Payment and cashiering. Payment and cashiering involves the collection and documentation of out-of-pocket amounts that the patient is responsible for. Pre-encounter communication about patient financial obligations is a great tool that helps facilitate encounter collections process. Payment and cashiering is more effective when it's done before the service is delivered. Concierge services. The term concierge is historically applied to the doorkeeper, and basically we know that from the hotel industry, and we've adopted that into healthcare. The concept has been expanded to indicate that the individual or service geared to the needs of the customer and their level of really gaining their level of customer satisfaction. These are services rendered to make the experience of the patient and the family as comfortable as possible and go far beyond those which have been traditionally associated with a hospital stay or a hospital visit. Some of these services may include valets, comfort lounges, business centers, baggage storage, deliveries, complimentary meals, reduced hotel rates, cabs. Concierge services could encompass any non-traditional activity to help patients and their families during this very stressful time. Transport and routing coordination. Some access departments are responsible for a formally organized department of transportation, which move the patients and their mail throughout the enterprise. Others assume responsibility more limited to transport of patients to and from a specific area. In the broad sense of transport and routing coordination refers to assisting patients and assuring their families that we're transporting them in a timely and safe arrival to the next and correct location. This is a function that's linked with scheduling and patient tracking. Coordination of transportation and routing contributes to the customer satisfaction through efficient service and helps ensure maximum utilization of resources. For example, care providers they don't have idle time to wait on patients. We have to keep things going. Wayfinding. In simple medical Facilities wayfinding may refer to signage system that directs patients, families, and visitors to their destination. With the growth of medical complexes and the onset of consolidation in physical environment may be very complicated. Directions that seem self-evident to employees and to the people who are familiar with the facility can be very confusing and very stressful to others. The best thing for wayfinding, if you can, is to escort your patient or guest to their destination. Wayfinding also encompasses such issues as directions and alternate means of transportation to the facility, location of parking and patient drop-off points in relation to the points of service, campus maps, visual cues such as color coding or repetitive designs. Patient information. This involves providing information by answering direct questions as well as anticipating customers' questions because its meaning is familiar in a non-medical context. Patients, families, and visitors utilize information for directions, patient room numbers, visiting hours, locations of services, as well as other hospital information. Family liaison services. Family liaison services involves all services that address the needs of the patient's families or visitors within and across the healthcare setting. This includes coordination and communication across the settings to ensure transition of families with the patients. Order entry. Order entry involves orders from the clinical services into the healthcare information system. Frequently involves some interpretation. When physician's terminology does not match with the expected standard, follow-up with communications may be required. For example, a physician may request a panel when Medicare requires tests to be ordered as a specific analysis. Charge capture. Charge capture is the process of electronically or manually applying appropriate predetermined fees associated with the service delivery. This can include order entry, charge entry, verification, and charge correction. The process must assure that charges are accurately applied to the correct account so that the process flows effectively to billing. Departure. This involves the preparation and actual departure of the patient from the encounter. Although departure planning occurs throughout the continuum of care, a smooth departure could include appropriate communication of the plan, responding to all questions, coordination of follow-up encounters, clinical instructions, pharmacy and nutrition, and counseling. And I just like to take a note and say that most of the time when we say someone has been departed or they're going through the departure process, it usually refers that the patient was an outpatient. We'll most likely say that someone who's an inpatient has been discharged from the facility. Post-encounter and future development. Major category: post-encounter and future development services. These services involve activities that support continuous improvement of patient access services, departmental and staff competencies. Post-encounter services include staff education and development, customer satisfaction audits, benchmarking and statistical reporting, productivity and accuracy tracking, resource management, physician relation management. Quality performance is an essential component in maintaining a patient flow that is efficient and timely and promotes high levels of customer satisfaction. It is imperative that each employee knows his or her role and is skilled with the competencies required by their role. Competencies are enhanced and improved by providing staff education with specific goals and are measured by comparison to established performance standards under annual evaluation. Customer satisfaction audits. The ability to provide undisputed professional courtesy, respect, confidentiality while collecting and completing an accurate information is the goal of customer service and patient access services. It involves the objective measurement of the level of satisfaction as expressed by the customers in relation to global processes or very specific issues. Benchmarking. Benchmarking is the formal comparison of quality of service, productivity, customer satisfaction, and/or costs with similar functional groups to process and performance improvements. Statistical reporting. Reporting may also include custom reporting created by specialists within the department, those arranged through in-house information services or outside vendor. It is important to know that the information an institution considers important and its daily activity and provide accurate input. Statistical reporting. Examining past surveys and audits may help to determine what ad hoc reporting capability is likely to be required in the future. It is important that data is saved and is in an accessible manner to meet federal, state, and third-party or other regulatory requirements. Statistical reporting provides timely summarized information for process improvement, administration and management, surveys and audits, Joint Commission, as well as requests from legal department. Reporting may be based on resources provided by health organizations, various online systems. Productivity and accuracy. As a facet of statistical reporting, these processes address the ability to professionally manage the volume of patient registrations while maintaining the desired level of data collection quality. They include performance measurements, having defined standards that are regularly monitored and reported. So with this particular image, I'm showing the number of total accounts, the number of total accounts without errors, and then total number of accounts with errors, and the percentage of demographic errors within that category. On with the review of the same 137 accounts, how many of those accounts actually had no billing errors, and how many had actual billing errors on that. And then, of course, what the overall quality score is. Now, whether you're doing a review of quality by hand or utilizing the system, it's very important that you take a moment to capture your productivity or have a tool that's used that is fair, not a subjective random count, but a consistent tool that you're able to see what your quality score truly is. Resource management. This process involves managing resources to accommodate physician and patient needs within and across departments or healthcare settings. Incorporates responding to statistical monitors through a scheduling system to adjust for patterns of delay and responding to individual physician or patient resource needs. Appropriately engages the team to respond for cross-functional problem solving. Physician relations management. Physician relations involves the coordination with physicians of the provision of care. It also includes the services provided to minimize the process steps necessary for physicians to achieve access for their patients. Good physician relations also involves the education of physicians about regulatory and process requirements. This concludes the course. Now this is the post-module assessment for Module 1. These questions will not be read out loud. Please take your time and answer all the questions. The answers will be revealed as each question takes place. Thank you so much for taking this whole entire module. If you'd like to send me any questions, please feel free to leave comments. I will respond. And if there's anything in this material you feel was inaccurate, you can let me know that too. But hopefully you enjoyed the content. Please let me know if you'd like to see Module 2. Thank you, and have a wonderful day or a wonderful night, and God bless. Once again, thank you so much. You completed the course and hopefully you rocked that post-assessment little quiz. See you in the next module. Thank you.